Congenital spinal anomalies represent a fascinating example of how small errors during critical developmental windows can create lifelong consequences. These conditions occur in approximately 0.5 to 1 per 1,000 births, making them common enough that you'll encounter them regularly in your clinical practice. To understand these anomalies, think of spinal development as a complex construction project where the building blocks must form correctly and then assemble in precise sequence. The critical period occurs between weeks 4 and 6 of embryonic development, when the basic spinal architecture is being established. During this narrow window, the somites are forming the individual vertebrae while simultaneously organizing into the segmented pattern that creates our normal spinal column. Any disruption during this period can affect the formation of individual vertebrae, their separation from adjacent levels, or both processes simultaneously. The clinical significance extends beyond the obvious spinal deformity because these anomalies frequently associate with other organ system abnormalities. Think of this as a developmental disruption that affects multiple systems simultaneously rather than an isolated spinal problem. The progression risk varies dramatically depending on the specific type and location of the defect, making accurate classification essential for predicting long-term outcomes and planning appropriate interventions. Understanding the classification of congenital spinal defects helps you move beyond simply describing what you see on imaging to predicting how the deformity will behave over time. This classification system organizes these complex abnormalities into understandable patterns based on the specific developmental error that occurred. Failure of formation creates hemivertebrae, where only half of a vertebra develops properly. Picture this as a construction project where half the building block is missing, creating a wedge-shaped vertebra that tilts the spine toward the defective side. These defects tend to create progressive deformities because the asymmetric growth continues as the child develops. Failure of segmentation produces bars or block vertebrae, where adjacent vertebrae fuse together abnormally. Think of this as building blocks that stick together when they should remain separate. These fused segments create areas of reduced flexibility and can lead to compensatory curvature in adjacent spinal regions. Mixed defects combine both formation and segmentation failures, creating complex patterns that can be challenging to predict and treat. The location of these defects determines the type of deformity that develops. Thoracic defects typically cause scoliosis, while lumbar problems often create kyphosis. Understanding this relationship between anatomy and deformity pattern helps you anticipate the clinical progression and plan appropriate monitoring strategies. The embryology of spinal defects provides crucial insights into why these conditions develop and how they create the clinical patterns you observe. During weeks 4 through 6 of embryonic development, the process of somite formation and differentiation establishes the foundation for the entire spinal column. Understanding this process helps you appreciate why such a narrow developmental window can have such profound long-term consequences. Think of somite development as a carefully orchestrated assembly line where each building block must form correctly and then separate from its neighbors at precisely the right time. During normal development, each somite differentiates into sclerotum tissue that will eventually form the vertebral body and neural arch. Simultaneously, the boundaries between adjacent somites must be clearly established to create the segmented pattern that allows spinal flexibility. Errors in segmentation occur when these boundaries fail to form properly, creating bars where adjacent vertebrae fuse together abnormally. Picture this as building blocks that stick together when they should remain separate. Errors in formation happen when the sclerotum tissue fails to develop properly, creating hemivertebrae where only part of the vertebra forms correctly. The complexity increases because multiple defects can occur simultaneously, creating mixed patterns that combine formation and segmentation failures. This explains why some babies have several different types of spinal abnormalities at various levels, reflecting the widespread nature of the developmental disruption during this critical period. Congenital scoliosis represents a fundamentally different entity from the more common idiopathic scoliosis that develops during adolescence. While idiopathic scoliosis affects a normally formed spine, congenital scoliosis results from actual vertebral anomalies that are present from birth, even though the curvature may not become visible until later in childhood, as growth makes the underlying structural problems more apparent. To understand this distinction, imagine the difference between a tower that leans because of wind versus one that leans because some of the building blocks are wedge-shaped or stuck together. Congenital scoliosis represents the latter scenario, where the structural abnormalities create inevitable curvature as growth occurs. This makes it a structural problem rather than a postural one, meaning that exercises or bracing alone cannot correct the underlying cause of the deformity. The clinical significance lies in understanding that 75% of congenital scoliosis cases will progress over time, making long-term monitoring essential throughout childhood and adolescence. Unlike idiopathic scoliosis, which typically progresses most rapidly during growth spurts, congenital scoliosis can progress steadily throughout development because the underlying structural abnormalities continue to create asymmetric growth patterns. This progressive nature requires vigilance, surveillance, and often early intervention to prevent severe deformity that becomes increasingly difficult to treat as it advances. The classification of hemiformation defects occur when the normal process of vertebral development fails to create a complete vertebra, resulting in hemivertebrae that appear wedge-shaped rather than rectangular. To visualize this concept, think of building a brick wall where one of the bricks is triangular instead of rectangular. This triangular brick will cause the wall to lean toward the defective side, creating exactly the same effect that a hemivertebra has on the spine. Vertebrae into complete versus incomplete types depends on whether the defect affects the entire vertebral body or just a portion. Complete hemivertebrae create more significant angular deformity because the entire vertebral level contributes to the curvature. The distinction between segmented and non-segmented hemivertebrae proves even more clinically important because it predicts progression risk. Segmented hemivertebrae have normal disc spaces above and below, allowing continued growth that worsens the deformity over time. Picture this as a wedge-shaped building block that can continue expanding, making the wall lean progressively more. Non-segmented hemivertebrae are fused to adjacent vertebrae, limiting their growth potential and creating more stable deformities. The location along the spine affects prognosis significantly, with thoracic hemivertebrae typically causing more progression than lumbar ones. Understanding whether the defects are balanced by compensatory curves or create unbalanced deformities helps predict the need for intervention and the urgency of treatment. Segmentation defects occur when the normal process of vertebral separation fails, creating abnormal connections between vertebrae that should remain independent. This concept becomes clearer when you think of spinal development as creating a chain where each link must form properly and then separate from its neighbors. When this separation fails, you get various types of abnormal connections that restrict normal spinal growth and flexibility. Block vertebrae represent the simplest form where two or more vertebrae fuse together completely, creating a solid segment without normal disc spaces. While this reduces flexibility, it often remains relatively stable because the fusion affects both sides equally. Unilateral bars create much more problematic situations because they tether growth on one side while allowing continued expansion on the opposite side. Picture this as tying down one side of a growing plant while allowing the other side to continue growing freely. The plant will inevitably curve away from the restricted side. Bilateral bars represent complete growth arrest, where both sides of the spine become tethered, preventing any further growth at that level. The clinical teaching point involves understanding that bars typically cause more progression than hemivertebrae because they create ongoing asymmetric growth patterns. A unilateral bar acts like a tether that becomes increasingly tight as the child grows, while the opposite side continues expanding normally, creating progressive deformity that often requires surgical intervention to prevent severe curves. Mixed defects represent the most challenging category of congenital spinal anomalies because they combine both formation and segmentation failures, creating complex patterns that are difficult to predict and treat. To understand why these combinations prove so problematic, Think about the mechanical forces involved when you have both a wedge-shaped building block and abnormal connections between blocks in the same area of construction. The most notorious combination involves a unilateral bar on one side with a contralateral hemivertebra on the opposite side. This creates what spine surgeons consider the worst-case scenario because you have growth restriction on one side combined with asymmetric growth promotion on the other side. Picture this as having a brake applied to one side of a car while pressing the accelerator on the other side. The result is rapid, uncontrolled turning that becomes increasingly severe over time. These mixed defects demonstrate highly progressive behavior because the mechanical forces work synergistically to worsen the deformity. The bar restricts growth on one side, while the hemivertebra promotes continued expansion on the opposite side, creating a powerful combination that drives rapid curve progression. This mechanical disadvantage explains why these defects often require early surgical fusion to prevent the development of severe, rigid curves that become increasingly difficult to correct. The poor natural history of mixed defects makes them prime candidates for prophylactic surgery, even when the initial deformity appears mild, because the progression potential is so predictably severe. Understanding progression risk factors for congenital scoliosis requires grasping the mechanical principles that drive curve development. Think of the spine as a growing tower, where each building block must expand symmetrically to maintain balance. When certain structural abnormalities disrupt this symmetric growth, predictable deformity patterns emerge that worsen over time. The unilateral unsegmented bar represents the highest risk factor because it creates a mechanical tether that always progresses. Picture a growing tree with a rope tied around one side. As the tree grows, the rope becomes increasingly tight, forcing the tree to bend away from the restricted side. This same principle applies to spinal bars, where one side cannot grow while the opposite side continues expanding normally, creating inevitable progressive curvature. Multiple unbalanced hemivertebrae compound the problem by creating several wedge-shaped vertebrae that all contribute to the same directional curve. Think of stacking several triangular blocks in the same orientation. Each wedge adds to the overall lean, creating a cumulative effect that accelerates progression. Growth spurts represent periods of maximum risk because the mechanical disadvantage becomes most apparent when growth rates increase dramatically. During these periods, the asymmetric forces created by the vertebral anomalies become magnified, leading to rapid curve progression. The thoracolumbar location proves particularly problematic because this represents the junction between the relatively rigid thoracic spine and the more flexible lumbar spine, creating mechanical stress concentration. Mixed defects carry the highest risk because they combine the worst aspects of both formation and segmentation failures, creating powerful forces that drive rapid, severe progression. Understanding VACTERL Association proves essential when evaluating any baby with congenital spinal anomalies, because this condition demonstrates how developmental disruptions during early embryogenesis can affect multiple organ systems simultaneously. Think of VACTERL as a constellation of abnormalities that cluster together because they all develop from closely related embryonic structures during the same critical time frame. The acronym helps you remember the key components. Vertebral defects form the spinal component we've been discussing, while anorectal malformations affect the digestive system terminus. Cardiac anomalies can range from simple septal defects to complex congenital heart disease. Tracheoesophageal fistula creates abnormal connections between the airway and digestive tract. Renal dysplasia encompasses various kidney abnormalities that can affect function. And limb abnormalities include conditions like radial dysplasia that we discussed earlier. The clinical significance lies in recognizing that finding one component should prompt systematic evaluation for others. When you encounter a baby with congenital scoliosis, you're not just looking at an isolated spinal problem. You're potentially seeing the first clue of a broader developmental syndrome that affects multiple organ systems. This understanding fundamentally changes your approach from isolated orthopedic care to comprehensive multidisciplinary evaluation. The interconnected nature of these abnormalities reflects their shared developmental origins during the critical 4th through 6th weeks of embryonic development. The screening requirements for babies with congenital spinal anomalies reflect the high likelihood of associated abnormalities in other organ systems. These protocols have evolved based on decades of clinical experience that demonstrate predictable patterns of associated conditions, making systematic evaluation essential for optimal patient care. Renal ultrasound becomes mandatory for all patients with congenital spinal anomalies because genitourinary abnormalities occur in 20 to 37% of cases. This high incidence reflects the close developmental relationship between the urogenital system and the axial skeleton during early embryogenesis. Think of this screening as recognizing that the same developmental disruption affecting spinal formation likely influenced kidney development simultaneously. Echocardiogram is indicated when clinical findings suggest cardiac involvement, occurring in 10 to 15% of cases. These cardiac anomalies can range from simple septal defects to complex congenital heart disease that requires immediate intervention. Spinal MRI becomes essential when neurologic signs are present because intraspinal anomalies occur in 20 to 30% of cases with congenital vertebral defects. Complete spine radiographs must document all levels because congenital anomalies frequently occur at multiple sites, and seemingly isolated defects often represent part of more extensive abnormalities. This comprehensive imaging approach ensures that you identify all abnormalities before planning treatment, preventing the discovery of additional problems during surgery that could complicate reconstruction efforts. Intraspinal anomalies represent hidden abnormalities within the spinal canal that can significantly complicate the management of congenital spinal deformities. Understanding these conditions becomes crucial because they often influence surgical planning and can cause neurological deterioration if not recognized and addressed appropriately. Tethered cord occurs when the spinal cord becomes abnormally attached to surrounding structures, preventing normal movement during growth and development. Picture the spinal cord as a rope that should slide freely within a tube. When it becomes stuck, growth creates tension that can damage neural tissue. Diastematomyelia involves splitting of the spinal cord into two separate channels, often with a bony or fibrous septum dividing them. Syringomelia creates fluid-filled cavities within the spinal cord substance that can expand over time, causing progressive neurological symptoms. Intradural lipomas are fatty masses that grow within the spinal canal, potentially compressing neural structures and tethering the cord. The clinical teaching point involves recognizing that these intraspinal anomalies occur more commonly when cutaneous markers are present on the skin overlying the spine. These skin findings serve as external clues that suggest more complex underlying abnormalities may be present. The association between surface markers and deeper anomalies reflects the shared developmental origins of skin and neural tissue from the same embryonic layers during early development. Cutaneous markers represent external signs that can indicate underlying spinal dysraphism or other intraspinal anomalies. These skin findings serve as important clinical clues because they develop from the same embryonic tissues that form the nervous system, making their presence a potential indicator of deeper abnormalities that require further investigation. Hairy patches overlying the spine, particularly in the lumbosacral region, can indicate underlying neural tube defects or intraspinal anomalies. These hair tufts appear different from normal body hair and often have a coarser texture or different color. Skin dimples, especially deep ones that cannot be fully visualized, may connect to underlying spinal abnormalities or represent incomplete neural tube closure. Hemangiomas appearing along the spinal axis can indicate underlying vascular abnormalities or neural tube defects. These lesions often appear as reddish, raised areas that may grow during infancy. Skin tags or other cutaneous appendages along the spine can represent remnants of incomplete neural tube development. The clinical significance lies in understanding that these markers indicate possible spinal dysraphism, a broader category that includes various forms of incomplete neural tube closure. When you encounter these cutaneous findings, they should prompt MRI evaluation to assess for intraspinal anomalies that might not be apparent on routine radiographs. The presence of these markers increases the likelihood of finding conditions like tethered cord, diastematomyelia, or other intraspinal abnormalities that can affect surgical planning and long-term neurological outcomes. Klippel-Feil Syndrome represents a fascinating example of how embryonic development errors can create a constellation of findings that, once understood, form a recognizable clinical pattern. To grasp this condition, think about normal cervical spine development as a process where individual vertebrae must form correctly and then remain separate to allow the remarkable mobility we expect from our necks. When this separation process fails during early embryonic development, adjacent cervical vertebrae fuse together, creating the foundation for all the clinical features you'll observe. The classic triad of short neck, low posterior hairline, and limited range of motion creates the characteristic appearance that makes this syndrome recognizable across the room. Picture how these features connect logically. When cervical vertebrae fuse together, the neck becomes shorter because you've essentially removed the spaces between building blocks. This shortened neck creates the low hairline because the same amount of scalp hair now covers a smaller area. The limited range of motion occurs because fused vertebrae cannot move independently, restricting the normal flexibility that allows us to turn and tilt our heads. Here's a crucial clinical pearl that prevents diagnostic confusion. Only 50% of patients demonstrate the complete triad. This means you'll encounter many babies with Klippel-Feil syndrome who have cervical fusions but don't display all three classic features. Understanding this incomplete presentation prevents you from missing the diagnosis in cases where only one or two features are present. The syndrome's significance extends beyond the obvious neck abnormalities because associated anomalies occur commonly, making this finding a signal to evaluate multiple organ systems rather than focusing solely on the cervical spine. The associated anomalies with Klippel-Feil syndrome create a pattern that reflects the interconnected nature of embryonic development during the critical 4th through 6th weeks of gestation. Understanding these associations helps you approach each case systematically while appreciating why certain organ systems cluster together in their abnormalities. Sprangle deformity occurs in 30% of cases, creating the combination of cervical spine fusion with abnormal scapular positioning. This association makes developmental sense because both the cervical vertebrae and scapula develop from related embryonic structures during the same time frame. When you encounter a baby with an elevated scapula, always examine the cervical spine carefully because these conditions frequently coexist. Renal anomalies affect 35% of patients, making kidney screening essential for every child diagnosed with Klippel-Feil syndrome. These abnormalities can range from minor variants to significant functional impairment, and early detection allows for appropriate monitoring and intervention when necessary. The high incidence reflects the close developmental relationship between the axial skeleton and the genitourinary system during early embryogenesis. Hearing impairment occurs in 30% of cases, often due to middle ear abnormalities or sensorineural hearing loss. This finding emphasizes the importance of early audiological evaluation because hearing problems can significantly impact language development and educational progress. Cardiac defects affect 14% of patients, requiring cardiac evaluation when clinical indicators suggest possible heart abnormalities. Scoliosis represents the most common association, occurring in 60% of cases. This high incidence makes sense because the same developmental disruption affecting cervical vertebrae often influences the entire spinal column. The clinical takeaway involves understanding that Klippel-Feil syndrome requires comprehensive, multidisciplinary evaluation rather than isolated treatment of the obvious neck abnormality. Congenital kyphosis represents a sagittal plane deformity that creates abnormal forward curvature of the spine, fundamentally different from the lateral curvature we see in scoliosis. To understand why this condition proves so concerning, think about normal spinal alignment in the sagittal plane. We have natural curves that balance each other to maintain upright posture. When congenital abnormalities disrupt this balance, they create progressive deformity that can have devastating consequences. The classification into Type 1 and Type 2 follows the same principles we've discussed for other spinal anomalies. Type 1 involves failure of formation, where the anterior portion of vertebrae fails to develop properly, creating wedge-shaped vertebrae that angle forward. Picture building blocks that are triangular instead of rectangular. They naturally cause the stack to lean forward. Type 2 represents failure of segmentation, where the anterior portions of adjacent vertebrae fuse together, creating a bridge that prevents normal growth while allowing continued expansion posteriorly. Here's the critical teaching point that makes congenital kyphosis more dangerous than scoliosis. This deformity is much more likely to cause paralysis. The forward angulation creates a sharp apex where the spinal cord becomes draped over the abnormal vertebrae, stretching and compressing neural tissue. Unlike scoliosis, which typically progresses slowly and rarely causes neurological problems, congenital kyphosis can progress relentlessly and create spinal cord compromise that requires immediate intervention to prevent permanent paralysis. Understanding why congenital kyphosis carries such high risk for paralysis requires visualizing the anatomical relationships that develop as the deformity progresses. Think about the spinal cord as a delicate rope that normally follows gentle curves within a protective tunnel. When congenital kyphosis develops, this tunnel becomes severely angled, forcing the spinal cord to drape over the sharp apex of the deformity like a rope stretched over a knife edge. The location of the kyphosis proves critical in determining paralysis risk, with thoracic deformities creating much higher danger than lumbar curves. This difference occurs because the thoracic spinal cord contains vital pathways for motor and sensory function to the lower extremities, while the lumbar region contains nerve roots that can better tolerate stretching and compression. Additionally, the thoracic spinal cord sits within a narrower canal with less room for accommodation when deformity develops. The sharp angular nature of congenital kyphosis creates the most dangerous scenario because gradual curves allow the nervous system to adapt, while sudden angulation creates immediate mechanical stress. Here's a sobering clinical reality. Paralysis can occur even with minimal deformity if the angulation is severe enough. This means that the appearance of the deformity doesn't always correlate with neurological risk. A relatively small but sharply angular kyphosis can be more dangerous than a larger, more gradual curve. This understanding explains why congenital kyphosis requires aggressive treatment, often involving early surgical fusion to prevent progression that could lead to irreversible neurological damage. Sacral agenesis represents one of the most profound congenital spinal abnormalities, involving the complete or partial absence of the sacrum, which forms the foundation of our pelvic architecture. To help you understand the significance of this condition, imagine the sacrum as the cornerstone of a building foundation. When this critical structure is missing or malformed, it affects everything built above and below it. This creates a cascade of problems that extend far beyond the obvious skeletal abnormality. The terminology becomes important for understanding the severity spectrum. When we refer to sacral agenesis, we're discussing absence of only the sacral vertebrae. However, when the condition extends upward to involve lumbar vertebrae as well, we call it lumbosacral agenesis, indicating a more extensive developmental failure that creates even more complex clinical challenges. The rarity of this condition, occurring in only 1 in 25,000 births, means that most practitioners will encounter it infrequently. However, the strong association with maternal diabetes creates a teachable moment about the importance of prenatal care and glucose control during pregnancy. When you understand that poorly controlled maternal diabetes during early pregnancy significantly increases the risk of sacral agenesis, you begin to appreciate how systemic maternal conditions can profoundly influence fetal development. This connection underscores why optimal prenatal care extends far beyond routine monitoring to include careful management of maternal medical conditions that can affect embryonic development. The classification system for sacral agenesis helps you understand both the anatomical extent of the defect and its functional implications. Think of this classification as describing how much of the foundation is missing from our building analogy. The more extensive the absence, the more unstable the entire structure becomes. Type 1 represents partial unilateral sacral agenesis, where only one side of the sacrum fails to develop completely. Picture this as having half of your foundation missing. While problematic, there's still substantial structural support remaining. Type 2 involves partial bilateral absence, where both sides of the sacrum are affected, but some sacral elements remain present. This creates more symmetric but still significant structural compromise. Type 3 represents total sacral agenesis, where the entire sacrum is absent, creating complete loss of the foundation that normally connects the spine to the pelvis. This represents a quantum leap in severity because it eliminates the normal structural continuity between the axial skeleton and the lower extremities. Type 4 extends the absence to include lumbar vertebrae as well, creating lumbosacral agenesis with even more profound implications. The clinical teaching point involves understanding that higher classification types correlate directly with worse prognosis. This relationship makes sense when you consider that more extensive absence creates greater structural instability, more severe neurological deficits, and more complex functional challenges. The classification system helps you communicate with families about expected outcomes and plan appropriate interventions based on the severity of the anatomical disruption. The clinical features of sacral agenesis create a recognizable pattern that reflects the profound impact of losing the normal connection between the spine and pelvis. Understanding these features helps you appreciate how a single developmental abnormality can create cascading effects throughout the musculoskeletal system. The small pelvis develops because the sacrum normally contributes significantly to pelvic size and shape. When this bone is absent, the pelvis appears disproportionately small and often assumes an abnormal configuration that affects both appearance and function. This altered pelvic anatomy creates mechanical disadvantages that contribute to many of the other clinical features you'll observe. Hip and knee flexion contractures develop because the altered pelvic anatomy and associated muscle imbalances create abnormal forces that pull these joints into fixed positions. Think of this as the body's attempt to compensate for the missing structural foundation by locking adjacent joints into stable positions. Unfortunately, this compensation creates functional limitations that significantly impact mobility and daily activities. Bilateral foot deformities occur commonly because the neurological abnormalities associated with sacral agenesis affect the nerve supply to both lower extremities. These deformities often include clubfoot, vertical talus, or other complex abnormalities that require specialized treatment. Here's a crucial clinical correlation. The motor level typically matches the bony level of involvement, meaning that the level of muscle function corresponds to the lowest normally formed vertebra. However, sensation may extend lower than motor function, creating a dissociation between what the child can feel and what they can control voluntarily. Managing sacral agenesis requires a comprehensive approach that addresses the multiple systems affected by this complex condition. The management strategy must account for both the immediate structural problems and the long-term functional challenges that these children will face throughout their development. Spinopelvic stability assessment forms the foundation of management because the absence of normal sacral anatomy creates instability at the junction between the spine and pelvis. Think of this as evaluating whether the remaining structural elements can provide adequate support for normal activities, or whether additional stabilization becomes necessary. This assessment often involves detailed imaging studies and biomechanical analysis to understand how forces are transmitted through the altered anatomy. Contracture management becomes essential because the muscle imbalances and altered mechanics create progressive deformities that worsen without intervention. This involves physical therapy, stretching programs, and sometimes surgical releases to maintain joint mobility and prevent fixed deformities that would further compromise function. Orthotic support plays a crucial role in providing external stability and enabling mobility for children who lack normal muscle control. These devices must be carefully designed to work with the altered anatomy while providing the support needed for walking and other functional activities. Bladder and bowel programs address the neurological deficits that commonly accompany sacral agenesis, helping children achieve continence and maintain health. The multidisciplinary approach recognizes that optimal outcomes require coordination between orthopedic surgery, urology, neurosurgery, physical therapy, and other specialists who can address the various aspects of this complex condition. When evaluating congenital spinal anomalies, your imaging approach must be systematic and comprehensive because these conditions frequently involve multiple levels and can be easily overlooked if you focus only on the obvious abnormalities. Think of this evaluation as conducting a complete architectural survey of a building where you suspect structural problems. You need to examine every floor, not just the area where you first notice damage. Complete spine radiographs from occiput to pelvis become essential because congenital anomalies rarely occur in isolation. What appears to be a single hemivertebra on focused imaging often represents part of a more extensive pattern of abnormalities that spans multiple levels. This comprehensive approach prevents you from missing additional defects that could influence treatment planning or prognosis. Counting ribs and vertebrae provides crucial information because numerical abnormalities often accompany structural defects. A child with 11 ribs instead of 12 or 6 lumbar vertebrae instead of 5 may have associated vertebral anomalies that require evaluation. Document all anomalies you identify because the pattern of abnormalities helps predict progression risk and guides treatment decisions. Measuring curves using the Cobb angle technique establishes baseline measurements that become essential for monitoring progression over time. This quantitative approach allows you to track changes objectively and determine when intervention becomes necessary. Planning follow-up imaging schedules ensures that you catch progression early when treatment options remain optimal, rather than waiting until deformities become severe and difficult to correct. Understanding the management principles for congenital spinal anomalies requires recognizing that these conditions behave fundamentally differently from acquired deformities like idiopathic scoliosis. This distinction drives every treatment decision because the underlying structural abnormalities create mechanical forces that cannot be overcome by conservative measures alone. Observation becomes appropriate for stable defects that show no progression over time and create minimal functional impairment. Think of these as structural abnormalities that have reached their natural equilibrium. They exist, but don't actively worsen. However, this observation must be vigilant and systematic, because even apparently stable curves can begin progressing during growth spurts or as the child develops. Here's a crucial clinical teaching point that differs from idiopathic scoliosis management. Bracing proves ineffective for congenital curves because external forces cannot correct underlying structural abnormalities. Unlike idiopathic scoliosis, where bracing can prevent progression of flexible curves, congenital deformities result from abnormal bone architecture that doesn't respond to external molding forces. Surgery becomes necessary for progressive curves because the underlying mechanical disadvantage will continue driving deformity throughout growth. Early fusion for high-risk patterns like unilateral bars or mixed defects prevents the development of severe, rigid curves that become increasingly difficult to correct. Growth-preserving techniques like growing rods or VACTERL devices help maintain spinal length while controlling deformity in young children, allowing continued growth before definitive fusion becomes necessary. Several fundamental concepts about congenital spinal anomalies deserve emphasis because they directly impact patient outcomes and represent frequently tested material that reflects real clinical decision-making. Understanding these key points helps you approach each case systematically while avoiding common diagnostic and management pitfalls. The mandate to screen kidneys with renal ultrasound for every patient with congenital spinal anomalies reflects the consistently high incidence of genitourinary abnormalities in these children. This screening isn't optional or based on clinical suspicion. It's a universal requirement because the developmental relationship between the axial skeleton and urogenital system creates predictable patterns of associated anomalies that can significantly impact long-term health. Progressive curves require early surgical intervention because the underlying mechanical disadvantage will continue driving deformity throughout growth. Unlike idiopathic scoliosis, where you can often observe curves and intervene later, congenital deformities with progression potential need prompt treatment to prevent the development of severe, rigid curves that become increasingly difficult to correct and carry higher complication rates. The clinical pearl that kyphosis proves more dangerous than scoliosis reflects the different risks these deformities pose to neurological function. While scoliosis rarely causes paralysis, congenital kyphosis can create spinal cord compromise that requires immediate intervention to prevent permanent neurological damage. Multiple associations occur commonly with congenital spinal anomalies, making comprehensive evaluation essential rather than focusing only on the obvious spinal deformity. Long-term follow-up remains essential throughout childhood and adolescence because these conditions can progress unpredictably, requiring ongoing surveillance and intervention as the child grows and develops.